Good morning, everyone, and welcome back to day 2 of the 4th edition of the Peninsula Infectious Diseases Conference. This morning, we have another great panel of speakers from San Mateo County Health, Stanford, and UC Davis. As stated yesterday, in the interest of time, I will only introduce the speaker's name and place of affiliation prior to the presentation, but their full bio is available in the conference program that was distributed to you when you registered either yesterday or this morning. Speaking of registration, if you attended the conference yesterday, please remember that you need to sign in again this morning, okay? Thank you. In terms of housekeeping, I will rapidly go over a few items, mostly again for those of you guys who did not attend the conference yesterday, those who missed the beginning of the conference. The conference today is scheduled to run until 12:30 p.m., and we will do our best to stay on time. I think we did a great job yesterday. We'll try to do the same today. Refreshment will be served mid-morning during a 15-minute break. Please note again that this is a tobacco-free campus and that food and beverages are not allowed in the theater. Again, as a reminder, when you exit the auditorium, there are restrooms to your right and to your left in the courtyard area. We encourage you to mingle again and to visit the exhibit tables in the lobby during the break. You will find information about HIV and STIs, tuberculosis, other reportable communicable diseases, as well as information regarding mosquito and vector control, the San Mateo County Public Health Laboratory, and immunizations for children and adults, to name a few. And for those of you who may have missed the talk that Dr. Shea gave yesterday, she offered to give you guys, those of you guys who are interested, a tour of the lab. So if you're interested, it will happen after the conference today, and so I think you can sign up at the exhibit. All talks will be 45 minutes long, followed by a 10-minute Q&A session. So please hold your question while the speakers give their presentations. Remember, please, to state your name and that of your organization before asking a question, and please use the microphone so that everybody in the room can hear your questions or your comments. For details about the schedule, please refer to the conference brochure. You should also have received a copy of most of the speakers' presentations, some handouts. Please silence your phones and step outside of the theater to take your phone calls. And now, without further ado, let's get started. I'm pleased to introduce our first speakers of the day, Ana Brantuela and Dr. Levy, who are here today to talk to us about the first case of MPOX Clade 1b in the Americas. Please join me in welcoming Ana and Dr. Levy.
Good morning. Thanks so much for the invitation to speak. It's an honor. So I'm Vivian Levy. I am the Chief of Infectious Diseases at San Mateo Medical Center, and I have the privilege of providing medical oversight for the Sexually Transmitted Infection Program. So today we're going to cover the epidemiology of MPOX, historical, and then the new sexual epidemiology that emerged in 2022, clinical recognition, prevention with the modified vaccinia Ankara vaccine that I'll call by the trade name Jynneos, the case review, which Anna, our program manager, will go into detail with, and the local health department response, and then lessons for other emerging and re-emerging pathogens and outbreaks. So just some history of the epidemiology. This is a zoonosis classically, which means it's transmitted animal to humans. The MPOX virus belongs to the orthopox virus genus, which includes variola virus that causes smallpox, vaccinia virus used in the smallpox vaccine, and cowpox virus. These double-stranded DNA viruses are very similar genetically and antigenetically, so you get cross-immunity from one virus to the other. It replicates at the site of infection, then spreads to the lymphatics, and then into the blood. So just a bit about the history. In 1958, the virus was first isolated in a Danish research monkey colony. That's where the name came from. And from 1958 to 1968, there were only monkey outbreaks with no human cases. In 1970, the first human MPOX case was identified. The virus was isolated from skin lesions in a 9-month-old boy from the Democratic Republic of Congo. He had fever. He had a rash with most of the lesions on the arm and legs, known as a centrifugal rash. He died 2 days later of measles before he was discharged from the hospital. From 1970 to 1971, West Africa had 6 additional human cases. Most were young children. None had received the smallpox vaccine. In 1980, global smallpox vaccination stopped and herd immunity declined steadily. In 2003, in the US, there's an outbreak due to Gambian pouch rat importation. These are rodents where they transmitted it to prairie dogs that were in an exotic animal facility. And the prairie dogs infected the humans, and it was mostly young adults and children that were infected. From 1970 to 1986, 7 countries in Africa had 2 clades. So the orange dots are the clade 1. This is typically more virulent. It's known as the Congo Basin strain. And then clade 2 is the West Africa in blue. And the case fatality rate in the literature for clade 1 is less than 1% to 11%, and clade 2, 0.1% to 3.6%. So in 2017, something really important happened. There was really the first description of MPOX being transmitted sexually. This happened in Nigeria. There were 500 suspected and 200 confirmed cases with a large number of adult males. There was an abundance of genital lesions suggesting sexual transmission, but the patients did not disclose interview data. It was a clade 2B lineage, and those have a marker of apolipoprotein B editing complex-like mutations known as ApoBEC3. And these mutations have only been seen since 2017, and they support clade 2B MPOX spread in humans can occur sexually, and it's been occurring since this Nigeria outbreak. There are no ApoBEC3 mutations in clade 1 or in clade 2A viruses. So in 2022, there was a case, the first case outside of Africa, was reported in the United Kingdom. It was in a man traveling from Nigeria, and the next few days there were unlinked cases with no travel history. These was mainly affecting gay, bisexual, and other men who have sex with men, which I'll call MSM. So the CDC releases a number of updates, health advisories, and situational awareness documents in May 2022. These basically talk about cases in non-endemic areas of Europe, North America, and Australia. Most are occurring in MSM. The CDC was working closely with US states and other countries, and as of early May, there had been 8 orthopox cases. As compared to 2018 to 2022, there had been 9. You can see before this, there had been in the US, UK, Israel, and Singapore. No flight contacts had developed infection, and 1 healthcare worker had developed infection and 2 family members. So the CDC communications really focused on this is presenting differently than classic MPOX. It's presenting really more as an STI. Some of these patients don't have the typical prodrome. The prodrome may be mild. It's unclear why we're seeing this unusual presentation. Patients are infectious from the time that symptoms begin until all of the symptoms scab and fall off. And what is asked of clinicians at this time is to be vigilant, to think about this diagnosis, especially when they're thinking about other STIs, to obtain specimens correctly, and to let the health department know for contact tracing and monitoring and lab testing. So here's an image, a photo of classic MPOX. So you can see these umbilicated lesions. Most of them are about the same age. It's really important to do the exam in a room with good lighting. The rash concentrates on the face, arms, and legs, again, centrifugal. And most of these lesions are at the same stage, and they can get a central belly button. So classic MPOX has an incubation of 3 to 14 days, up to 3 weeks. The prodromal symptoms are typical. They are usually come first, and then the rash starts 1 to 3 days. And they talk about fever, headache, fatigue, muscle aches, swollen lymph nodes, skin rash, and the rash progression was macules flat to papules raised to vesicles, fluid-filled to pus-filled to scabs, different from varicella zoster, which usually does not have lymphadenopathy. And you can get oral lesions, face, arms, legs, and hands and feet. And again, pre-symptomatic transmission would be 1 to 4 days before symptomatic onset could also occur. So here's some photos of that rash progression. So macule to papule to vesicle to pustule to scab. So again, one could see lesions at any of these stages. And here's some of these genital lesions. These are known as typical because you see this umbilication pretty clearly in these images, especially the ones that are not yet scabbed. These are less typical lesions. I would say these look somewhat like cankers, especially the ones that have these heaped up margins, more like syphilitic cankers or bad herpes ulcers. And here is another pox virus, not an orthopox virus, but a pox virus, molluscum, and you can see similar appearance to monkeypox with umbilications. So again, these can happen in the palms, the soles, the face, and can be similar distribution to secondary syphilis. Oral lesions can occur, mucosal site lesions. So again, just to highlight the differences, so classic MPOX had this fever, flu-like symptoms, and lymphadenopathy, which with the 2022 outbreak was really more mild or not occurring, or the systemic symptoms were happening after the rash. The rash could mimic other STIs. They were different age lesions as opposed to with classic. They were synchronous. They were focused in the genital and perianal areas and often didn't go to other areas. And you could have very severe pain and co-infection with STIs, including anal infection, proctitis. So patients were hospitalized in 2022, especially patients with AIDS, had a lot of morbidity. And these are some of the reasons for hospitalization. Pain was a big reason for hospitalization, but also superinfection, severe bowel lesions, urethral strictures, severe oropharyngeal lesions, and even eye, heart, brain complications. Most of the severe complications were in patients with low CD4 counts and HIV. So for clinicians, it was emphasized that it was extremely important to get a travel history to Central and West Africa when they saw patients, and also to ask about sex partners, if there was male-male sexual contact, and if they were meeting partners through apps, bar, party. In July of 2022, the World Health Organization declares a global health emergency. So in May of 2022, the testing for us and local health departments was a two-step process. The state labs that are part of our lab response network were doing a generic orthopox virus test that could test for orthopox DNA, and in somebody who had a consistent syndrome that was known as a case. There was a confirmatory PCR, but at that time it was only available at the CDC. So transmission, it was thought that this virus was not easily transmitted. It was mostly transmitted sexually through skin-to-skin sexual contact, but it could be transmitted direct or indirect contact with body fluids, lesion materials, fomites, respiratory secretions, shared towels and bedding, skin-to-skin contact, and being inside a room within 6 feet. So for healthcare workers, they were supposed to wear full PPE of gown, eye protection, and N95. So infection control was emphasized for healthcare providers who were testing patients, keeping it on their differential, and basically, as much as able, putting patients in a single-person room and having them cover their lesions and wear a well-fitting mask. So at this time, treatment was mostly supportive, but there was the antiviral tecovirimat. Since then, the PALM trial in Africa and the STOMP trial in the US have shown non-effectiveness of tecovirimat. It didn't decrease lesion number or severity. So basically, it's really supportive care that is current standard of care. Contacts need to be monitored for 21 days, and really as early as possible. When you have a suspect, it was important to let the health department know. Post-exposure prophylaxis was with 2 US licensed vaccines, and the Jynneos was strongly preferred. and there was pre-exposure prophylaxis for healthcare personnel and really for all at-risk persons. So I'll just talk a little bit about Jynneos. It's a live modified Vaccinia Ankara vaccine. It's a third-generation smallpox vaccine with a virus that cannot replicate in humans. The virus used in the vaccine is attenuated through multiple passages in non-human chicken embryo cells, so it leads to loss of virulence but still retains its immunogenicity. It doesn't produce a lesion. You'll sometimes hear this term, a take. That's basically known a lesion at the site of vaccination. So it's really the preferred product as opposed to this ACAM vaccine. Maximal immunity with the Jynneos vaccine is 2 weeks after receiving the second dose, and there's really still limited data on duration of protection. So Jynneos was available. Initially with some issues with supply, but soon after, fairly readily available. Again, the Jynneos vaccine is preferred. It doesn't have risk of inadvertent inoculation and auto-inoculation. It has a lot less adverse events. So, and really the only contraindication to Jynneos is a severe vaccine allergy. So as far as effectiveness, observational studies of the Jynneos vaccine have ranged from 66 to 89% for pre-exposure prophylaxis with this vaccine for 2 doses and 36 to 75% with 1 dose. Persons who receive this vaccine are much less likely to have severe syndrome if infected. So this was a study by colleagues at CDPH. Basically, it was a phone interview study of 4,600 men in California with MPOX, and they basically estimated vaccine effectiveness against progression to disease of disseminated lesions. And they found vaccine effectiveness against progression of 59% total, 67% in HIV negative, and 45% in HIV infecteds. And pre-exposure vaccination was associated with less severe illness needing hospitalization, reduced odds of fever, chills, lymphadenopathy. And the post-exposure vaccine was really less effective, 16% against progression. So some benefit, but less. So here's the map of where we were in August 2024. Our case presented in November 2024. So you can see that yellow color is really most of the world. A lot of the world has Clade 2 cases, and really the solid blue and the solid green is confined to Africa. Those are the Clade 1 MPOX cases. And here's what was happening in California around that time. There was a peak in fall of 2022. San Mateo County was in the top 10 of 60 counties of rate of MPOX per 100,000 residents. And testing was still low in California and really remained low during the acute phases of the 2022. So here you can see in October 2023, they were finding a positive prevalence of 25 to 27%, so extremely high. This is just to bring you up to date. Last month, cases increased modestly in San Francisco. Since late June 2025, they had 14 San Francisco residents with MPOX, which was an increase of about 1 per month from January to May. So really a call for vaccination was released by San Francisco, ourselves in San Mateo, and CDPH. And again, just recognition, testing, notify the health department, and vaccination, ideally pre-exposure. So there have been disparities in who's received the Jynneos vaccine and who has had MPOX. Here you can see in 2023 data, 45% of cases were among Latinos, but only 27% of them had been vaccinated, and 13% among African Americans, but only 7% had been vaccinated. HIV-infected persons are much more likely to have severe disease or even death. And among 38 MPOX deaths in the US, 94% of those with available HIV status had HIV. They're usually people with low CD4 counts. So it's especially important to vaccinate HIV-infected persons, and vaccine coverage among people with HIV was below 30% at this time. So the recommendations that are in place now are the same ones that were in place in 2023, all at-risk persons with a focus on MSM, male-male sexual contact should receive the 2-dose Jynneos vaccine series. And most recently, the recommendations were updated in MMWR June 2025, unchanged. Really, boosters are still not recommended for fully vaccinated persons, including immunocompromised. For those interested, there's a really nice open forum infectious disease article about duration of immunity. It's preliminary, but 2 years post-exposure, they looked at IgG to vaccinia virus in 122 persons, and natural immunity measuring IgG was about 85%, and vaccine protection was 32%. But it's thought that maybe it's not just IgG that protects against this virus. There may be robust memory responses. Other arms of immunity are important. So I'm going to turn to Anna and the case now, this is how our case presented on day 0. He was coming back from Africa, and on the plane, he noted some fevers. On day 2, those fevers continued to 1013, chills, dyspnea, fatigue, nausea, and he had some unilateral inguinal lymphadenopathy, a 1 centimeter purulent draining ulcer at the penis base, and multiple tender left inguinal nodes. No other rash or lesions were present. His gonorrhea, chlamydia, and lymphogranuloma venereum gnats were all negative. They didn't ask travel history when he presented to 2 urgent cares on that day. On day 4 to 6, his symptoms continued. The pubic ulcer appeared to be healing, but the lymphadenopathy was still present. Now he had a forearm pustule, so he was hospitalized for 3 days at a county facility for presumed inguinal cellulitis. He was dehydrated. He developed some acute kidney injury that resolved with fluids. Travel history was not assessed during that hospitalization. On day 7, the inguinal pain worsened. The rash spread on his arms, face, back, legs, and he went to a 3rd healthcare facility where he disclosed he had traveled to East Africa, and swabs were taken to send to a commercial lab for non-variola orthopox and MPOX Clade 2. So I'll turn it over to Anna.
So we received the report through an electronic lab report through CalReady system. We received an orthopox virus non-variola DNA PCR detected and an mpox virus DNA PCR not detected, and mpox virus DNA Clade 2 not detected. And we know currently commercial labs and public health labs perform orthopox virus non-variola DNA and mpox DNA Clade 2 testing. So when this was reported to me from the staff, I knew this was going to be highly suspect of a Clade 1. We also received a report from the health facility number 3, IDMD, called a provider line and was requesting guidance on this discordant result. The state also would notify a local jurisdiction when they saw this discordant, but they do it at 6 a.m. These labs came in during the morning, so there is a 24-hour delay. So at that point, we knew we needed to get into a rapid response. And so there's a lot on the slide because a lot happened on that day, but I think one of the key things, the key actions and meetings were happening. The provider documentation was really crucial for us to begin our analysis and our case investigation. So first thing that I did was assign a communicable disease investigator, or CDI, we also call them disease intervention specialists, to get a copy of those results, or the medical records, so we can begin to look through those. And so some of the things we're looking for is onset dates to determine our critical period, any international travel within 21 days of the onset. We're also getting information about the index case. Are they immune compromised, comorbidities? Is this someone that might have a severe outcome? We're also looking at, the clinicians sometimes will put information about if they work in a sensitive occupation or situation. That it was incredibly helpful to see that, and also sometimes they'll put something about their household contacts. I also knew we needed to get a hold of that specimen. We're at day 11 after the initial swab was done, so I signed a CDI to call the commercial lab to see if we can locate that specimen to send it over to the state. And then I assigned the case to Munya Mejia, one of our CDIs, and we do a pre-interview conference. There's a case report form that has information, but we really wanted to zone in on some of the things. We were reviewing those medical records. I did. Michelle Malong, who is one of our CDIs, was also looking at those medical records. So it was really important that we have several set of eyes on these medical records. And so Munya, when in our case pre-interview conference, we really talked about some of the things he really wanted to get information on, to obtain new information or confirm some of the things that we were seeing in the medical records. So confirm those symptoms, ask about household contacts, close contacts during the period when the person was having symptoms, travel dates and locations and any travel companions. And we knew at that point the person had gone to several medical facilities, so we knew that's where we were really going to be concerned about possible spread. So asking that person, where did you go? You went to urgent care. Did you get checked in? Did you have an exam? And really talk about some of the activities and procedures that were happening. The other thing is they're doing is giving education about MPOX and also giving isolation guidance for themselves on any household contacts. And one thing we do, we want to prepare this index case. We had to tell them that it is highly likely that it's going to be a Clade 1, and this would be the first one in the United States. So it's important for they understand that this is going to be high profile, reassure their confidentiality. But one of the most important things is that we tell them to really maintain their own confidentiality. We learned with MPOX, people sometimes out of their own concern, they may call their work, they may call someone and really disclose that, but we really wanted to tell them, maintain that confidentiality. And we educate them about the role of public health, is that our role is really to assess if somebody needs to be, or a site needs to be notified. So allow us to do that and allow you to just focus on getting well. And Munya Mejia did an excellent job. I think one of the things that developing rapport and letting them know we're going to be calling you multiple times. And he was able to really establish really strong rapport with this individual because he was very open and was really understood the importance and really was able to give us a lot of information. We did end up calling him multiple times. And so the interview was done within an hour of assignment. And simultaneously, I was notifying our leadership. I was notifying Dr. Levy, the state lab, and notifying the STD control branch. And then they were, in turn, were notifying CDC. And so a meeting was held about 3 o'clock that afternoon, 3 or 4 o'clock, to give us, they were giving us a guidance, but they also requested, Dr. Jacobson requested another specimens to see if we can get that. So Dr. Levy, who was actually home, had to turn around and came back. And so we decided we were going to go into the field. So I assigned Wes Ewan, who's here as our senior CDI, to prepare a go kit. So we were going to be going into the field, making sure we had PPEs, guidance, and all the specimen collection. And so we're at day 11 on that same day. We prepared to go into field to collect that specimen. We didn't want to have the individual go to a site. And so we notify Dr. Shea, Christina Shea, our public health lab, to let her know we're going to be bringing in a specimen late. We need to get that over to CDPH Richmond campus fairly quickly. So Dr. Levy and I did a quick training for ourselves on PPE, donning and doffing, how we were going to handle the specimen, and also talk about how we were going to approach going into this building complex. And we did notify the patient, let them know that we're going to be there, open the door quickly. We don't want to be standing out there with PPEs just to maintain, again, your confidentiality. So we prepared before we went into the field. So we went into the field between 6 and 7. Dr. Levy was able to collect 2 more specimens for the forearm. We did a re-interview. Again, we're trying to confirm all the information on the NSEP because we did have some discrepancies. And then we reviewed infection control measures, which was really good because this person was in a 1-bedroom a site with 1 household contact. And so they had, the household contact was in the bedroom, they were in the living room that had a couch. He said, well, I'm sitting on the couch, and we also said, well, you need to cover the couch. And so we were able to actually give some good guidance to the individual. And I think it was helpful for us to be there because at that point they're feeling very isolated, and so let them know that we just need to take some precautions. So it was a very good interview there. We were able to interview the household contact who was asymptomatic. We advised MPOX vaccine. We referred them over STI clinic, but they ended up actually going to CVS and getting that the next day. We advised work restrictions because the person was a healthcare worker. And the reason we did that was Dr. Levy and I looked at the literature from the early UK case that was identified in early November, and that had 3 secondary cases, and they were all household contacts, so we were very restricted on this point. So Dr. Shea did a wonderful, got that specimen over to CDPH by 9 a.m. We got the results at 3 p.m., and it was a Clade 1 detected. Further testing for the serotyping was going to be done at CDC. So communication started happening between CDC, CDPH, and our leadership and our communication officers to really determine what information was going to be released. So that following Saturday morning it was released, and they released the information that the first Clade 1 was identified in our county. And then within hours, all media outlets was reporting that the first U.S. Clade 1 was identified. So we on that weekend was very busy. We were really concerned about spread. We were trying to do containment activities. We were focused on identifying close contacts in the follow-up. So there were travel companions, and the state was able to follow up with those individuals who lived out of state. So they did those notifications to those state health departments. Household contact, Munya was doing daily checks on symptoms, and the bulk of the work was with our healthcare facilities. So we did a notification to the infection control programs. Our senior public health nurse, Shay Waterman, for our TB program was involved with that, notifying these ICPs, and that's where they were the ones who were doing a lot of this work. So they began to identify healthcare workers and that came in contact with this individual, and environmental staff for when the person was hospitalized for 3 days. They're very concerned with any cleaning staff that was handling any of the soiled linen and things like that. So they were developing a line list of all these staff. They did the initial notification of exposure to these individuals. They then also assessed the level of exposure. And so here's a tool that the state gave us on what is a high risk, and high risk really was if somebody had a broken skin and came in contact with that lesion. We didn't have any high risk. We did have some intermediate and low risk. And the vaccine, Genius vaccine was offered, PEP was offered at any level of risk. Very few medical healthcare workers were vaccinated. Once we did a quick check, we were able to check this, found that the people that were on the line list were not in the care immunization database. So from that contact list, the state was very much involved with using an automated daily symptom monitoring system. And so the contact would receive a text through their phone. They would sign up, and they would receive a text twice a day. They would report if they had symptoms or not. If they did report symptoms, and this was during flu and cold season, so people had symptoms of things, so the state would do an initial call. They would initially call the contact and assess their symptoms. If they reported any lesions or rashes, they would report that back to the health department and infection control, and a CDI would be assigned to call them and get more information, and we would coordinate testing actually at the facility. We did train, we did have our public health nurses from our TB program. We did a train just in case we were going to have to go out and do another specimen collection, but we did not do that. So they were returning to their facility to get tested. So we were giving guidance to the ICP programs on collection of specimens and handling and getting them over to the state. So the outcome, we had 83 total contacts identified who lived in different Bay Area counties and states. We had the 1 household contact, 4 travel companions, 10 flight contacts of the CDC. They identified that through the flight manifest. And we had 68 healthcare personnel. 6 of those individuals had incidental lesions on their necks, backs, and legs, but they were negative for orthopox DNA, not detected. We did have 4 that received PEP. And 77 of the 83 were enrolled in the automated symptom check. So we had no secondary cases, and Dr. Levy and I went back out on day 23. She did an exam and cleared the index case cleared, so they were no longer had to be isolated. At that point, that was day 0 for the household contact. That household contact did have to be work restriction for 21 days after that. And this is just a picture of on day 7 when the initial swab was done, the positive test was on day 7. The second is day 11 is when Dr. Levy collected the specimen, and then day 23 is when there was clearance. And this next slide is just an overview of what we just went through from day 0 to day 23. And the infection did not result in a severe illness, and the patient recovered with no further conditions. Dr. Levy.
So we'll just close with some lessons learned for other outbreaks. So one, a disease affecting one region of the world can have a strong effect on areas where it is not endemic, with different target populations and new clinical presentations. It's important for all of us to keep up with the CDC Health Action Network and California Health Action Network mailings. Targeted pre-exposure vaccination needs to be stealth, nimble. It's important to get a travel and sexual history. If MPOX is in the differential and testing is being done, please call us at the health department, even with suspects. Shoe leather epidemiology, a hands-on and field-based approach and field specimen collection was crucial in this case. Trained communicable disease investigators like Munya, Wes, Michelle are huge allies and tools, and so valuable during an outbreak with the trust and rapport that they've established with staff and communities. Shout out to the physician who called us with the same day the lab result arrived. Importance of our partnerships with infection prevention and control systems in the county, wearing PPE when you suspect MPOX. We need to do a better job explaining and promoting post-exposure prophylaxis. Our lab diagnostic and surveillance infrastructure is hugely important. We should keep it well, even when at times when we're not having an outbreak, and vaccines are really important and work. So Ann and I just want to express a lot of gratitude locally. A lot of people were involved in this response at the state, at the CDC, and thanks to national and state colleagues who provided slides for this talk. Hi, Kim.
The comment is, when this patient presented multiple times, I think it's important for all of us to understand the reason we got the diagnosis was because of a very astute emergency room doctor. He was the one who took that travel history and who thought outside the box and then called us saying, could it be? And of course we said very unlikely. But that emergency room doctor was the key to getting this diagnosed, and the way the infection preventionists at Millis Peninsula jumped into action was a huge part of all of this. And so I think all of us need to keep our emergency room doctors, who are really the frontline people, well educated and well informed about what's going on, especially because we are in this international environment where people are coming in through SFO. In terms of how this patient got it, as you mentioned, he was not sexually active over there, but he described himself as a hugger. He went there for a wedding, and I think met a lot of people and hugged a lot of people, and that's what happened. So that's my comment. Question I have, though. Back in...
Kim, I'll just add, because I think it was... He also, when he was in Africa, he says that he had kind of an open lesion in the groin when he went there, maybe a folliculitis, but he also got a full-body massage.
There you go.
Yeah.
There's always risks involved. The question I have, though, is back after 9/11, many first responders got vaccinated against smallpox, and I don't think it was the Jynneos vaccine. I'm not sure which it was. Would you anticipate that those individuals who got vaccinated 20 years ago would be protected against MPOX, and if they were exposed, they would not need to get revaccinated?
So it's a really good question. You know, I think the author is Byrne, B-Y-R-N-E. There's this open form infectious disease article, we really don't know how long immunity lasts with the smallpox vaccine for MPOX. And we know that natural immunity seems to be better than vaccine immunity, but it's still preliminary. I would say it's at the lab study stage. It's not at the clinical recommendation stage of how long protection lasts. It's a really good question.
Great, thanks.
Yeah. And I agree completely with emergency department, the point you made about how important they are as colleagues. Yeah.
Hey, Vivian. Great job. I just wanted to say thank you for all your work here in this case, and for the public health, your whole compadres who did such a great job. But I think there are two key takeaways. One is get a travel history. People don't get travel histories. And as Kim mentioned, we are, we're connected globally. We have SFO in our backyard. And people do travel. And so if you never ask, they won't tell. And even that case of Ebola in Texas, where the patient died, it was a case where travel history actually was taken but never transmitted to the providing person. So even if it is taken, again, it has to go to the right place, right? So that's one thing. And secondly, though, I do think the vaccine issue, calling it a live vaccine, it is a live vaccine in that it's an attenuated virus, but it's a non-replicative virus. And that's crucial because actually that vaccine, the Jynneos vaccine, can be given to a pregnant woman, which we do not do. We do not give pregnant women live attenuated virus vaccines because there is a risk if your own immunity is too low, which happens with pregnancy, the virus can start replicating and harm a fetus, right? So I do think the vaccine is underused. We're not promoting it. The fact that more healthcare workers did not get it is really a crime. I mean, if you have the vaccine and it's available, protect yourself. And again, smallpox. So I was around for the original from 9/11, when there was a fear of a smallpox use of bioterrorism weapon, when anthrax went through the mail, right? So that vaccine, the other vaccine, is a live virus, and you cannot give it to anyone who has, and actually, I couldn't get it because my spouse has a history of psoriasis. And that's how, because with a live smallpox vaccine, you can actually get smallpox from the injection site, from the, the protective Band-Aids. So bottom line, the Jynneos vaccine is a huge improvement. It's much, much safer. It's 2 doses, and people should get it. Thank you. That's my
Thanks
take.
so much, Grace. Grace is a huge resource as our infection control officer for San Mateo Medical Center, so talk to her if you see her around. She's a wealth of knowledge, and she knows firsthand how much work these healthcare-associated infection outbreaks can be. Thanks, Grace.
Hi, great presentation. Thank you for sharing. Cheryl Flessner from Sequoia Infection Prevention Program. So I'm wondering, for any of us who have seen HICPAC disbanded, it's just a shame. But for this kind of isolation, it really doesn't have a great label. We have airborne droplet contact, but like COVID and things like MPOX, it's suggested to wear an N95, no negative pressure. And so I'm wondering if, has anyone from CDPH talked about creating some kind of label? So we use signs in the hospital so that our folks know what kind of PPE to wear. So is there any talk about what do you do with this certain category? We're calling it enhanced droplet. So I don't know.
Do you know, Anna?
No, but that's something that we can definitely give the recommendation to CDPH. That's good to get that feedback.
Thank you.
Hi there, my name is Stephanie. I'm a communicable disease with Sonoma County here with my colleagues. We were mostly wondering how the household contact was supported during that long isolation period.
How the household contact was supported
How were they?
21 days.
I mean, in terms of just, we were giving daily guidance, so our CDI was in contact with them. In terms of support, what do you mean in terms of support?
How were they able to stay compliant with the home isolation? Was they financially supported? Was there loss of job income?
No, they were in a position where it was not a problem. The person was able to actually do some work, do teleworking type work. But that is a good question. If somebody had to, in terms of equity, was somebody able to do that? So that is something we definitely need to be looking at for anytime somebody is restricted.
Thank you.
I will just add, because if the health department is restricting, they can get a letter that they can submit to their employer. And as SDI, some of those things might be eligible if it's been a certain amount of time. So that's something to always be looking for if somebody had to be restricted beyond like the 7 days for SDI.
I just wanted to say thank you. Hi, Cheryl. How are you? So just the infection control aspect for MPOX. First of all, in general, it is considered a droplet exposure, not aerosol. So I think by now we all understand the difference between droplets and aerosols, right? Droplets are big and they fall to the ground relatively quickly. Aerosols are tiny and stay in the air. So with a true aerosol disease, ideally you need HEPA filtration and what's called an AIIR room, meaning we take the air out in negative pressure, right? So if you have a droplet disease, however, which are things like flu and RSV, these are not considered airborne, they are droplets. For those diseases, you don't need that incredibly potent filtration. What's a disease that is a mycobacterium is TB. That is airborne. It is not droplet. So that's why TB patients, like COVID, must be in the negative pressure room, taking the air out. For MPOX, it's not considered to be airborne. Now, I will say, with all newer infectious diseases that hit the Western world, it takes time, and it can take years before we truly understand the full characteristics of the virus. And that happened with COVID. When COVID came out initially, it was considered to be droplet. And it was not. It was airborne. But you have to do the studies to prove it. This is what science is about. This is part of our problem with people pointing fingers and saying, you lied, you didn't know. When scientists don't lie, they tell you the evidence they have. But that evidence changes over time when more evidence is gathered and different conclusions can be made. So the bottom line is for MPOX, although it's considered droplet, it's still, if you are face to face with a person and you're close and you are exchanging conversation, you're inhaling those droplets. You're inhaling all the aerosols, everything coming out of that person's mouth. So for MPOX being a disease that has a high morbidity, mortality, potential mortality more with Clade 1 than 2, Clade 1b, nonetheless, we use the highest level of protection we can to protect our healthcare workers. We use fit-tested N95s to be sure that no one gets anything transmitted to them in the care of a patient. Nurses are face-to-face with patients for many, many minutes to hours over a day. And so we have to protect them. Doctors can be too, depending on what you're doing and how much of a physical exam you're doing, how much of a history you're taking. So the bottom line is, in infection control, we err on the side of protection of the healthcare worker. That's how we save lives. That's why we don't have transmission to our staff if we follow those guidelines. Thank you.
Thanks so much, Grace. And one of the main lessons that CDC wanted to learn from this incident was the healthcare-associated infection transmission piece. So absolutely, they're still gathering knowledge. Thank you.
Thank you. It was a great talk. I have a couple of questions for you guys. So one about vaccines. You talked about the fact that not very many people are immunized. So what can we do to hopefully increase the uptake for that vaccine? And then maybe that's a question for you, Anna. And then for you, Dr. Levy, what about treatment modalities? What's the role of TPOXX? I think we're like saying, no, maybe not so good. And then are there any other treatment modalities in the pipeline? Any other antivirals, anything?
So I'll do the easier. So yeah, tecovirimat, I think the fact that it didn't show effectiveness in the large trials that were done in Africa, PALM, and the US STOMP trial for decreasing lesion severity and number really makes it less useful. There's some studies being done on IVIG. I think other antivirals are still in the quite early stages with limited evidence. I really think vaccination is the right question, Dr. Stalinov. I agree completely because it really decreases severity, and we know it works.
I think just in promoting, I think your conference here, getting this information to providers and doing the health departments are doing provider detailing. That's another way of getting the information out. And when you go to CDC, they do have recommendations, MSM, and down the road it does talk about healthcare workers. So I think it's really about promoting that. Just currently, while you can get to the CDC website, is actually downloading that information, printing it, and having that available when people go out and do some provider detail and education. So I do just want to, for more information about our case, it is, MMWR was released, and so you can get some more information on the actual case.